This is a video about ultrasound in the diagnosis of endometriosis, ABCDE. My name is Suzanne Johnson and I'm a gynaecologist from Southampton. Endometriosis is a common gynecological condition affecting around 5% of women. It's defined by the presence of stroma and glands outside of the endometrial cavity, and this is hormonally responsive, leading to cyclical pain, bleeding, inflammation, fibrosis and the formation of adhesions. Endometriosis is a cause of pelvic pain, dysmenorrhea, dyspareunia, dyschezia, subfertility, or it can be asymptomatic. There are three kinds of endometriosis. There is superficial endometriosis, Ovarian endometrioma, and deeply infiltrating endometriosis, DIE. And DIE is when endometriotic lesions extend for more than 5 millimeters underneath the peritoneum, surrounded by inflammation and dense fibrosis. It's not certain what causes endometriosis, but there are theories of retrograde menstruation and/or metaplasia. The mean delay between a woman having symptoms and a diagnosis of endometriosis is 8 years. And 1 in 3 women had consulted their GP at least 6 times before referral and diagnosis. The symptoms can overlap with other conditions like irritable bowel syndrome, and it can be diagnosed on ultrasound, MRI and laparoscopy. A pelvic ultrasound, though, is often said to be normal, and patients are told that there is nothing wrong, which leads to long delays in diagnosis. But you need to look for deep infiltrating endometriosis, mobility of frozen pelvis, and site-specific tenderness on ultrasound to make the diagnosis. In 2016, the International Deep Endometriosis Analysis Group published this paper, and it's a consensus opinion on terms, definitions, and measurements to diagnose endometriosis on pelvic ultrasound. They have defined this as being useful to do in 4 steps, and these can be done in any order. And the first step is a routine pelvic ultrasound of the uterus and adnexa, looking for signs of adenomyosis and ovarian endometrioma. The second step is looking for soft markers like site-specific tenderness and ovarian mobility. The third step is looking at the sliding sign as mobility in the pouch of Douglas. And lastly, looking for DIE nodules in the anterior and posterior compartments. But you can do these steps in any order. And this video is to tell you how I use the ID classification. I start with a systematic routine pelvic ultrasound looking for the features of endometriosis like adenomyosis, ovarian endometrioma and ovarian adhesions. Then I look for the sliding sign in the pouch of Douglas. Then I look for nodules of deep infiltrating endometriosis, and lastly I look at the soft markers of site-specific tenderness and pelvic mobility. When I do a systematic transvaginal scan of the pelvis, I don't routinely ask the patients to have a bowel preparation. The main thing is to be really gentle and to have the patient's position in a good way, so that the patient's bottom overhangs the edge of the couch a little bit and either has knee supports or a chair for the feet. And then I always say, let your knees go floppy, as this really relaxes the legs and the pelvic floor. Then I slowly insert the transvaginal probe with plenty of gel on the outside of the probe and perform a normal systematic pelvic scan, looking also at mobility and tenderness. And in women in whom I diagnose DIE, I will also do a transabdominal renal scan, as 3% of women with DIE might have silent hydronephrosis. Most of my images are in the longitudinal view, and I'll mention in the video when it's in the transverse plane. But generally speaking, this is the way that I'm oriented, with bladder at the top, then uterus underneath that, and bowel below. The first thing I look for is what position the uterus is in. And so here you can see an anteverted uterus where the uterus tilts toward the bladder, B for bladder, or a retroverted uterus where it tips backwards away from the bladder. But in endometriosis you often see a uterus that is anteverted but retroflexed, as the fundus of the uterus here is pulled backwards by adhesions. So in this orientation, the bladder is here. In this video, you can see a uterus with adenomyosis. You can see that it's bulky, it's globular, there's an indistinct endomyometrial junction, and there's stripy shadowing, a little bit like a luxaflex blind. In this video, you can see a different uterus with adenomyosis where there are islands of endometrium in the myometrium. This is an adenomyosis. And on 3D, you can see those islands as little outpouchings from the cavity. In this view on 3D, this is the myometrial fundus, this is the right side, and this is the left side, and the cervix is at the bottom. You can see a very irregular endomyometrial junction. This is typical of adenomyosis. In this video, you can see an ovarian endometrioma, and it is adherent to the uterus, to the back of the cervix. You can see it there. And this now is in the transverse plane, where you can see this is low down level of the uterus, and this is an ovarian endometrioma, a unilocular cyst with no solid material, some shadowing and ground glass echogenicity adherent to the back of the uterus. And to compare that with the normal ovary on the patient's other side, you can see that when I very gently press the probe in and out, very gently, you can see that this ovary cantilevers a little bit. It's freely mobile. Here again is a transverse plane. This is the back of the cervix. The back of the cervix is here. And here you can see an ovarian endometrioma adherent to the back of the cervix and also adherent to the other ovary. And this is a less obvious endometrioma, and this is called kissing ovaries. Often in reports on women who later turn out to have endometriosis, there's a comment that the ovary is low. And at that point, the transverse view is very useful. You must suspect adhesions when you see an ovary this low. So here you can see the bladder again is at the front. This is the uterus, the cervix. This is the back of the cervix. And here is this ovary adherent to the back of the cervix. And in this plane, you will see that it is attached to uterosacral ligaments, but more of that later. And here is the difference between a heavy ovary, a polycystic ovary on this side, and an endometrioma, which is adherent to the uterosacral ligaments. Both are low in the pelvis, but one is freely mobile, and the other one is an endometrioma, and it is adherent to the uterus. The other thing you look for is hydrosalpinges, because the fallopian tubes can be affected by endometriosis, but mainly it's due to adhesions near the ovary, and you especially see this when you have kissing ovaries. So here again in this longitudinal view, you can see a uterus and then the ovary, and here is the hydrosalpinx. And if you do 3D of that area, sometimes it shows you very clearly that this is a definite hydrosalpinx, and it's a unilocular tubular mass with thick irregular walls, incomplete septa, an anechoic or echogenic fluid content, and you may have shadowing. The next thing I do is look for the sliding sign in the pouch of Douglas. Now these papers were published in 2013, almost simultaneously, talking about how to judge mobility in the pelvis. This is an example of an anteverted uterus, and if you have your probe in the anterior fornix, this is the plane that we're most familiar with, you can see the cervix, and you'll be able to see the sliding sign of the cervix against the bowel just there. If you put your probe in the posterior fornix, you won't be able to see the cervix because it's pushed over that way, but this is a very good way to look for bowel nodules and adhesions, but more of that later. So for the sliding sign in an anteverted uterus, the probe needs to be in the anterior fornix to look for mobility at the back of the cervix. But if the uterus is retroverted, then when you have your probe in the anterior fornix, you can see the cervix, but it's quite difficult to judge mobility at the back of the cervix, which is where we need to look in the pouch of Douglas. But if you put the probe in the posterior fornix, then again, you can't see the cervix because you've pushed that away, but you'll now be able to judge the sliding sign of the uterus against the bowel in the pouch of Douglas, and will also look and find bowel nodules and adhesions. So this is a normal sliding sign. It's an anteverted uterus. The uterus is tilted toward the bladder here, and the probe is in the anterior fornix. I can see the cervix, and I can see the back of the cervix moving freely against the bowel. Normal sliding sign. And here's an example of a normal sliding sign in a retroverted uterus. I've now put the probe in the posterior fornix, so the cervix is pushed to the side. But when I press very gently with my probe, you can see that the back of the uterus and the back of the cervix is entirely free from the posterior structures. So what does the pelvis look like at laparoscopy? We've seen a normal sliding sign. What would that patient's pelvis look like? You just have to understand that when you do an ultrasound, this is the patient's right and this is her left, and we're very familiar with that. But at laparoscopy, the pelvis is inspected from this way, so looking toward the patient's feet. So in this view, you're looking at the back of the uterus. The bladder is in front of the uterus, and on these sides you can see the ovaries, you can see the fallopian tubes, but most importantly here at the back of the uterus, this is the torus. This is an area where one uterosacral ligament and another, they join on the back of the cervix, and this is the pouch of Douglas just beneath it. And the torus is incredibly important in ultrasound for endometriosis. So the torus is the insertion of the uterosacral ligaments on the posterior cervix. So what does that look like as an abnormal sliding sign? You remember the normal sliding sign where we looked at the torus and the structures move freely. And this is an abnormal sliding sign. You can see here that the posterior structures are adherent to the back of the cervix. This is an abnormal sliding sign in an anteverted uterus. An abnormal sliding sign in a retroverted uterus. We've got the normal sliding sign on the left there, and you can see probe in the posterior fornix, gentle pressure. You can see that uterus is completely mobile. But then on this side, again, I'm pressing gently with my probe. You can see that all this is adherent to the back of the uterus and the back of the cervix, which is up there. So a frozen pelvis, what does that look like at laparoscopy? You can see here, this is the back of the uterus. These are the ovaries, which are adherent to the back of the cervix with dense adhesions, and the bowel is just behind there. And that was this sliding sign that was negative. So having done a systematic pelvic ultrasound and looked for the sliding sign, I'm now going to look for nodules of deep infiltrating endometriosis. As I said, DIE is when you have endometriotic lesions which extend for more than 5 millimeters underneath the peritoneum, and you get cyclical bleeding here with inflammation and fibrosis. The result of that is some irregular hypoechoic solid nodules which look dark, with minor vascularity usually, surrounded by brightly echogenic white fibrosis. So the nodules tend to stand out rather. Where can you find these lesions? You can find them in the bladder, ureter, posterior vaginal fornix, maybe involving the lower rectum, retrocervical area of the torus and uterosacral ligaments, a retrocervical nodule involving either the posterior vaginal fornix and or the lower rectal wall, a rectocervical nodule involving the rectal wall of the upper or lower rectum, and then it can be in the lower rectum, upper rectum, sigmoid, some other areas, and also cutaneous. Looking at the most common areas where we look for DIE, there's the anterior compartment comprising of bladder and ureters, and the posterior compartment of the posterior vaginal fornix, retrocervix, and rectum. So if you look at the area where the bladder joins the uterus and draw a line backwards, that will go through the internal os and behind that level at the torus. So you always look for where the bladder inserts on the uterus, internal os will be behind it and torus will be behind that. So this is where the uterosacral ligaments attach to the back of the cervix. If you draw another line down the external cervical os, then the area between vagina and bowel up to that red line is called the rectovaginal septum. The bit of vagina that is here below the red line, or above the red line in reality, this is the posterior vaginal fornix. And this underneath is the pouch of Douglas. And this is peritoneum, which dips down to about the level of the external cervical os, and then of course covers the back of the uterus and the bowel. This green line showing you where the torus is divides the bowel into lower rectum and upper rectum. So a common location for DIE is in the bladder, in the posterior vaginal fornix, at the torus, in the lower rectum or the upper rectum. At laparoscopy, this is as far as you can see. You can only see as far as the pouch of Douglas is open. But if you have DIE, everything can become completely glued together, and this is called a frozen pelvis. And this is what a frozen pelvis looks like at laparoscopy. So again, we're looking at the back of the uterus. This is the right ovary, and here is the pouch of Douglas. There are adhesions here. You can see that everything has got glued together. So looking now at the posterior vaginal fornix at lesions of DIE. The rectovaginal septum is the septum between the lower 2/3 of the vagina and the lower rectum and anal canal, and I have never seen endometriosis there. But the posterior vaginal fornix is the upper third of the posterior vaginal wall. It's above the level of the cervical external os, and in many papers the posterior vaginal fornix is called rectovaginal septum. But in fact the posterior vaginal fornix is a common location for DIE. So again, just looking at that again, with that red line that you draw past the external cervical os, the 2/3 of the tissue between the vagina and the bowel is called the rectovaginal septum, but the upper third here, this is the posterior vaginal fornix, and it is here that you can often find lesions of DIE. Here is an ultrasound image showing you the anatomy slightly better. This is the cervix, again seen in a longitudinal plane. There's the external os. This is the vagina. That's the lower bowel. That's the rectovaginal septum. And then this is the pouch of Douglas. So how does that fit in with the posterior vaginal fornix? This is a video showing you that. This is the posterior vaginal fornix. There is the external os, the internal os, and this is the posterior vaginal wall, and this is it as it merges onto the posterior cervix, just there. And it looks white here because there's a little bit of air in the vagina. So this is the posterior vaginal fornix, and then the rectovaginal septum will be just laterally to it there. And this is just a longitudinal plane going from one side to the other, just showing you where that posterior vaginal wall inserts on the cervix. So this is a common location for deep infiltrating endometriosis, and we're calling it the posterior fornix, but some people call it rectovaginal septum. And this is a video showing you that here is the posterior vaginal wall, this is the external os, that's the cervical canal, and here you'll see in a video in a minute a lump of deep infiltrating endometriosis in the posterior fornix. This is the probe being introduced. Always look carefully as you introduce the probe, very gently, and there you can see deep infiltrating endometriosis in the vagina with a nodule extending onto the lower bowel, but I'll show you more pictures of that in a moment. So for now, look at the posterior vaginal fornix. There's a lump of deep infiltrating endometriosis there, and you can see it almost immediately as you insert the probe, just there. And these lesions sometimes are a little bit vascular, usually not too strongly so. And if you do a speculum examination, looking at the posterior vaginal wall, just at the top third there, you can see this nodule of DIE, and it's kind of eroded through the vaginal epithelium. Next we come to the retrocervical area of the torus and the uterosacral ligaments. Looking for DIE, this is a really good trick. You start by visualizing the torus. So the torus is where the uterosacral ligaments attach on the back of the cervix. So I start with a longitudinal view, looking for the area where the bladder, which is this white echogenic line, attaches to the uterus. In a line behind that is the internal cervical os, and in a line behind that is the torus. This is more or less where the uterosacral ligaments attach, and I'll show you what this looks like. Live, start longitudinally, and then I'll rotate on this point of the torus and go transverse. So this is the view in the longitudinal plane, going from one side to another. Now I'm rotating to the transverse plane. This is the torus, this is the right uterosacral ligament, and this is the left uterosacral ligament, just there. So rotate on the torus, go from longitudinal to transverse. I've got torus at the back, and I've got the right uterosacral ligament just there, and the left uterosacral ligament just there. And that looks like this. This is the back of the uterus again. This is the torus with the left uterosacral and the right uterosacral ligament, and there's an ovary and a bit of tube. Torus, very important area. So having looked at the torus, I then look at the uterosacral ligaments, both sides. You will see them if you look at the torus specifically. You can also stretch them over the posterior vaginal fornix during gentle pressure with the probe. The ligaments are white, and they can be very thick and white fibrotic, and if there are nodules of DIE in the ligaments, they will be dark, so they show up well. This is a transvaginal longitudinal view. This is the posterior fornix, the cervix is up there, and the uterus is retroverted. And here you can see just a little bit of normal fluid in the pouch of Douglas. This dark is the posterior vaginal wall, and then the white is the peritoneum overlying it. And I'm going to show you a uterosacral ligament, which will come into view here, that when I press slightly harder, it will blend with the peritoneum. I'll show you. There is the uterosacral ligament. I'm now pressing slightly harder, and you can see how it blends into the peritoneum. So again, looking at the torus, get a longitudinal view of the internal os, rotate to transverse, and then you're looking at the correct area with the uterosacral ligaments. So the retrocervix, the area at the torus, would look like this in a normal longitudinal view, but this is somebody with endometriosis, and you can see thick white fibrosis of the torus and the ligaments, and you can see a dark nodule at the torus. This is the normal transverse plane of the torus, and you can see here very thick and fibrotic uterosacral ligaments. So looking at the retrocervical area, looking at the torus, if you use high frequency, including harmonics, and move your focus up to very high, this is the posterior vaginal wall, then you can look at the torus and the ligaments in more detail, and you'll see a dark nodule there in this white fibrotic region. So you need to be sure to move your focus up to the area that you're actually interested in and go for high frequency. Of course, if you use harmonics, you have relatively higher frequency still, and that will examine that area nicely. So here we're a little bit high, you can see a bit of cavity, but this is essentially a normal torus. And in this torus, you can see a dark nodule of DIE with very thickened fibrotic uterosacral ligaments. And the image underneath is the same patient seen at laparoscopy. And you can see here is a nodule of endometriosis at the torus with very thick ligaments just nearby, and a lot of adhesions. So once you've found a retrocervical nodule, then we need to think, does it involve the posterior fornix and or the lower rectal wall? Here again is the uterus, the cervix is up there somewhere. Here we've got the vagina, and I'm looking at this white area in the longitudinal view. This is all fibrosis. And here this retrocervical DIE is adherent to the posterior vaginal fornix and adherent to bowel, and you can see an ovary is stuck into this area as well. Here we've got a nodule of deep infiltrating endometriosis, which is adherent to the posterior vaginal fornix and adherent to bowel and involving bowel. And I'll show you that in a moment. There's the nodule of DIE at the torus. There is the attached but not involved posterior vaginal fornix, and here is the bowel wall. And in the video, this is what that looks like. There's the probe going down the vagina into the posterior fornix, and there you can see a bowel nodule just there. You can see it's going down, you can see some fibrosis, and you can see the bowel nodule. This would be lower rectum, and in this video I'm just looking at the bowel nodule in a bit more detail. We'll talk about those more in a moment. There's the retrocervical nodule, and it's attached to bowel and involving the bowel. There is the nodule at the torus. And you can look at the bowel nodule and you can see that the lumen there is quite narrow and the lumen there is much wider. And at laparoscopy you can see here that there's bowel adherent to the torus. Here we can see some retrocervical DIE, which is adherent to the posterior fornix but also involving it, and adherent and involving the bowel wall too. There is the posterior fornix DIE, there is the retrocervical nodule, and here is the bowel nodule in the lower bowel, lower rectum. And this is what that looks like on ultrasound. So the probe is in the posterior fornix. You can see there's a lump of DIE in the posterior fornix. You can see a nodule in the ligaments, and you can see a bowel nodule too. So when you're describing retrocervical DIE at the torus, you have to say, is it in the torus or maybe in the uterosacral ligaments or in all of them? And what does it extend onto? Does it extend onto the posterior vaginal fornix, and is it maybe also involved with DIE? Does it extend onto the bowel? That would be lower rectum and or upper rectum. And is it only adherent, serosa, or is it involved, a muscularis layer of the bowel? Or any combination of the above, especially when people have had previous surgery. Looking for bowel nodules now in the lower rectum, upper rectum and sigmoid. A bowel nodule is again ectopic endometrial tissue in the muscularis layer this time, resulting in inflammation, smooth muscle hyperplasia and fibrosis. And it results in a hypoechoic mass in the muscularis layer. Mostly this is in the rectum, whether it's upper or lower. 20% of cases are in the sigmoid, 15% in the right iliac fossa, either appendix, ileum or cecum, and it's often multifocal. Looking at normal bowel first, the probe is in the posterior fornix, and you can see here again, you can see normal posterior vaginal wall. You can see here the normal overlying peritoneum, and it's not thickened. This is the pouch of Douglas, tiny little bit of fluid. And then you can see that this white layer is the serosa. The dark layer here with the white line in between, that's the muscularis layer. And the white layer is where the outer longitudinal and inner circular fibers join each other, and you get a little white line of connective tissue. That makes you realize that's got to be the muscularis. Deep to that, you've got the submucosa and mucosa. And then it repeats again on the other side, submucosa and mucosa. And this one is the muscularis, this layer, and then here you've got the serosa. So the lumen of the bowel is here. Endometriosis is always in the anterior wall. And this is what it looks like. a little bit of normal muscularis. So this is the layer that we're looking for, muscularis. There it's normal, there it's normal, and here you can see this thick lump of DIE that has caused smooth muscle hyperplasia. So you can find bowel nodules particularly through the posterior fornix. So we're used to looking through the anterior fornix because you can see the cervix, you can see the sliding sign of the cervix against bowel, but you'll struggle to see bowel nodules because they will be hidden by the cervix. Whereas if you put your probe in the posterior fornix for both an anteverted and a retroverted uterus, you can't see the cervix because you've pushed it that way, but you will be able to see bowel nodules and adhesions. So this is how we do it in the longitudinal view. This is the cervix. You can see the external os, the cervical canal, the internal os. There's a little bit of dark, that's just some mucus. You can see the posterior vaginal wall, and then this bit is the posterior vaginal fornix. And the probe here is in the anterior fornix because I can see the cervix. What I need to do is move it from the anterior fornix into the posterior fornix. And the way we do that is we very gently withdraw the probe a little bit and then angle it more in a posterior direction and gently insert it. And this is what that looks like. So there's the normal sliding sign. I'm pulling it out slightly, angling it backwards. And there you can see posterior vaginal wall, and the probe is now going into the posterior fornix. And that allows me to see the pouch of Douglas and the bowel in a lot more detail. It's much easier this way to see bowel nodules. I'll just show you that one more time. There is the cervix in the longitudinal plane. I'm going to pull the probe out a little bit, then angle it more backwards toward the sacrum, and very gently nudge the cervix out of the way, stretching the posterior vaginal fornix over the tip of the probe, and now I can see the pouch of Douglas really clearly. So I'm in the posterior compartment now, and I'm looking for DIE. So again, draw the line where the bladder attaches to the anterior uterus. Then here is the internal os. Behind that is the torus. And then I've drawn a line past the external cervical os. This is the rectovaginal septum, where I've never seen endometriosis. Here is the posterior vaginal fornix, where I often see endometriosis. This is the peritoneum lining the pouch of Douglas. I've got, through this line separates out lower rectum from upper rectum, and that is at the point of the uterosacral ligament insertion on the cervix. And any bowel that's beyond the level of the uterine fundus is called sigmoid. So common locations for DIE in the posterior compartment are the posterior vaginal fornix, the retrocervical area of Torus and Uterosacral ligaments, and the rectum with the lower rectum and the upper rectum. But the disease is often multifocal and it can attach everything together, resulting in frozen pelvis. So the classification for bowel DIE is that superficial bowel endometriosis affecting the serosa only is not DIE. To have DIE, you need to have an involved muscularis layer. And as we just saw in the diagram, the lower rectum is below the torus, the upper rectum is above the torus, and it is this that is visible at laparoscopy, and the sigmoid is above the level of the uterine fundus. So here you can see the dark muscularis layer, and here you can see a very superficial nodule of endometriosis that's not made the muscularis layer thick, so it's not DIE. But here you will see a nodule of DIE in the lower rectum. There's the probe going into the posterior fornix, that's the posterior vaginal wall. Bit of fibrosis there, and here is a nodule in the lower rectum. It's connected to the posterior vaginal fornix, but not involving it, because you can see that the posterior vaginal fornix itself is very white, very dark and thin, so it's not thickened and it's not involved. And here you can see the bowel nodule, and this is the muscularis layer. If you look overlying it is the submucosa, and it's white and it looks quite regular, so it's probably not involved. And this is the muscularis layer of the posterior wall. And when you put colour on, you can see this nodule does not have much vascularity, it's not suspicious. So this is an example of involved lower and upper rectum. Looking at the picture here, uterus in the longitudinal plane, draw that line of bladder, internal os, torus, and you can see that this bowel nodule affects both the level below this line, below the torus, which is lower rectum, and above it, which is upper rectum. And this is what that will look like on the moving image. There's the probe going into the posterior fornix. You can already see the bowel nodule. It's very large just there. I'll just let that play one more time. Coming into the posterior fornix, you can already see it. There's dense fibrosis behind the cervix and an attached nodule which stretches from lower to upper rectum. Here I've got a uterus with a very large plaque of endometriosis affecting the upper rectum and the sigmoid, and this is what that looks like. There's the uterus, and there comes this really thick dark plaque of DIE and the huge ovarian endometrioma all attached to one another. So this is upper rectum and sigmoid. Sometimes you see separate bowel nodules. So in this example, we've got nodules in the lower rectum and in the sigmoid colon. And I'll play this one. Here we are in the posterior fornix. The cervix is up there somewhere. And you can see sweeping from side to side, there's a very large bowel nodule there in the lower rectum, in the anterior wall. It was a nodule that's attached to the torus and the uterosacral ligaments, but it centers on the insertion of the posterior fornix to the back of the cervix. And then when we looked a little bit further, near the left ovary, as you can see, there are two nodules in the sigmoid colon. There they come again, just one and two there. And you can see some normal muscularis in between. There's some normal muscularis there. So two nodules in the sigmoid colon and one very large retrozoical lower rectal nodule. How to measure a bowel nodule? A lot of people measure the distance from the anal verge, but I find this very difficult. The most common location for Bowel DIE is at the torus, and at that point you're around 8 centimeters from the anal verge. What we do in Southampton is we measure the distance of the nodule to the torus, whether it's mainly above the torus, and that's upper rectum and it's intraperitoneal, or whether the nodule is below the torus, which is lower rectum or retroperitoneal. And this is where bowel surgery can be very difficult, and people often use a bowel surgeon for endometriosis surgery in this area. We then measure the nodule in 3 dimensions, length, depth and width, on 2D and on 3D. And it's important to measure the length of a lesion as a curved line if the lesion is not linear. I'll show you. We then measure the angle of the involved muscularis layer and the degree of affected circumference in the transverse plane. And these are markers for the risk of bowel stenosis from the lesion, and comment on submucosal involvement. So this is what it looks like. Here again is a retroverted uterus. When the torus is around there somewhere, but you can see here that there is something attached to the back of the uterine wall above the level of the torus. And in this plane you can see this is the bowel nodule. There's some normal muscularis there. It becomes normal again here, and it's at here and here. So this is, and it's flat. You can see how this is entirely flat. And in the transverse plane, this is the normal bowel, and then this is the bowel nodule, and you can see it's less than half of the diameter there. You can also see the nodule of DIE in the very thick fibrotic torus uterosacral ligaments just attached to it. But this is a curved bowel nodule, and so you have to draw a curved line following the length of it. In this case, the angle here is 90 degrees or less, which is a worrying sign. This is the depth of the nodule, and you mustn't include the depth of the torus nodule. It has to be just muscularis. And then in the transverse view, you can see this is transverse bowel, and here you can see the endometriosis. And again, you need to measure as a curved line and work out whether or not it's what percentage of the circumference you think is being affected. And we suspect bowel stenosis if you have this kind of a mushroom nodule where the angle is 90 degrees or less, or if more than half of the circumference is affected, or if the AP diameter is more than 1 centimetre. These are signs suspicious for the nodule in the bowel causing bowel stenosis. You can also do 3D. If you look here at the bowel nodule, I've applied 3D to it and I've rendered that, and here I've got a nice bowel nodule, and there is the nodule, retrocervical nodule attached to it. I quite like to do 3D because it improves the view of the DIE in the uterosacral ligaments, and it gives you a nice submucosal view usually. You have an improved view to measure the width of the bowel involvement, which is, as I said, a surrogate marker for stenosis. And you have to know that colonoscopy of this lesion, where the colonoscope comes in this way, is usually normal. So it's very handy to be able to look at it with 2D, 3D and 4D. If you rotate your image around, it gives you a slightly better idea that this lesion, as you can see, it's very, very retracted, might well be causing significant stenosis. So when I report on a bowel nodule, I'll say the number of bowel lesions and where they are, what the relationship of the nodule is to the torus. Is it below the level of the torus or above it? What is the size of the lesion, excluding any superficial disease? I'm saying the length, depth and width, the angle of the lesion, and then whether it's likely to be stenosing or not, and if there's submucosal involvement. And so you can see that on frozen pelvis, ultrasound can see so much more than a laparoscopy. Here we've got the back of a normal pelvis, a normal uterus, a normal torus and uterosacral ligaments. And here you can see a frozen pelvis where everything is glued together. And views of the pouch of Douglas are very challenging. You can't really see what's going on down there. Whereas on ultrasound, we could see that the sliding sign was negative. The ovary, the uterus, and all the bowel behind are all attached to each other. In this transverse plane, you can see an ovarian endometrioma and a normal ovary. They're kissing ovaries and they're attached to the back of the cervix. But then significantly on ultrasound, we can see that there was also a nodule of DIE in the bowel wall that was not visible at laparoscopy. Ultrasound can see deeper than laparoscopy. Looking for DIE in the bladder and ureter, I usually do this last because I ask people to come with an empty bladder, and so during the rest of the scan the bladder's been filling up a little bit, allowing me to see it better at this moment. So this is where I'm looking in the area of the trigone and the base, and looking at the lower ureters, and this is what it looks like. In a longitudinal view again, there's the urethra, there's the bladder, and that is where one of the ureters is inserting into the posterior bladder wall at the trigone. And I'll show you, I'm going to do in the longitudinal plane, I'm sweeping from left to right, and you'll see both ureters enter the bladder. So this is where you need to look. This is where the ureter there comes into the bladder. There it goes. Ureter into bladder. There's the urethra. I'm going out the other way now. And there is the other ureter. There's the left one. Passing through the urethra, out the other side. And there is the right ureter. This is how you know it's ureter. This is the lower ureter, and you can see vermiculation. Completely normal. It's like peristalsis of the bowel. And so this is urine that's entering the bladder here at the top of the trigone. And if you look transversely, it looks like this. So this is the right ureter entering the bladder, this is the top of the trigone. This is a jet of urine seen on colour Doppler, and the other side is also emptying beautifully. So that's normal. This is DIE in the posterior bladder wall, and here you can see a huge lump of DIE in the posterior bladder wall. Quite unusual, and quite unusual to have it that badly. It's usually a lot more subtle. The ureters can also get involved with DIE. It can be at the point where they enter the bladder, or it can be much more commonly at the back of the cervix. and that's where you need to be looking. And most ureters that are affected by DIE is by external compression and fibrosis of the surrounding tissues, and occasionally it's muscularis in the DIE in the muscularis layer itself. And here you can see there's that ureter as it just comes out of the bladder. I'm tracking it laterally. There's the ovary, and there it becomes very wide. This is where it's being pinched. So you just go to the bladder and you look at where the ureter enters the trigone, and you track it laterally toward the pelvic side wall, toward the ovary, and then you have to look above the ovary. And you can see that here. This is the lower end of the ureter. This is as it's glued to the ovary and it's dilated at this point, and you can see that here. You can see that the ovary is fixed to the pelvic side wall and it is trapping the ureter there. And this is a 3D image. You can see this is the nodule of DIE in the pelvic ligaments. You can see these little tongues, protrusions of tissue as they're almost look like they're invading the ligaments. But you have to look above that, so you need to increase your depth of field to look above the ovary. And you know it's ureter. You may or may not be able to see vermiculation. It's not a vessel, because on colour Doppler this is what a vessel looks like, and this is not lighting up, it's the ureter. There's the DIE. This is a different case. This is a longitudinal view of the uterus. This is an adherent ovary, and here you can see a dark lesion that doesn't light up with colour. You can see a nodule there with fibrosis, and if you look at the video then you can see there's some vermiculation, and the ureter becomes very adherent here to the back of the cervix. And when I looked at this patient's kidney, you can see that she's got moderate hydronephrosis. This is yet another case where again this is in the retrocervical area, where you can see that there's a nodule of deep infiltrating endometriosis. This is it on 3D, when you often get a more clear view, and you can see the ureter is very dilated above it and normal below it. And this patient had severe hydronephrosis on that side. And this is usually silent and asymptomatic, so you need to go and look for it in women who have got DIE. Lastly, there is cutaneous DIE and malignancy arising in endometriotic lesions, but that's for another talk. Lastly, I look for soft markers, site-specific tenderness and pelvic mobility. The main thing to say is be very gentle. I do this at the very end of the scan, and I go through the pelvis systematically again, asking whether it's painful in this area whilst you're looking exactly where you're scanning, so you can see what is it that's so tender. You can gently press on the uterus and gently press on the adnexa, then the ovary, then the bowel, then the pouch of Douglas. Go around it in a logical sequence, looking especially carefully for if an area is very tender. Look for DIE, because you'll probably find some if you haven't already seen it. And judge mobility once more in all these areas. And this, if sometimes I put a hand on the abdomen, so in this case left hand on the abdomen, right hand holding the probe, and you can see this ovary is extremely mobile. They're not normally as mobile as that, but that's nice. So having gone through all the different stages, this is a live scan where we're going again breaking it up piecemeal and showing you what it shows for the report at the end. So here you can see a longitudinal view of a uterus with islands of endometrium in the myometrium, and that's adenomyosis. You can already also see adherent ovaries with endometriomas at the back. So this is at the very start. Here you can see these islands of endometrium in the myometrium, and you can see an adherent ovarian endometrioma at the back of the uterine fundus. In the longitudinal view, this is the right ovary, and it's an endometrioma, a unilocular cyst with no solid component and some ground glass echogenicity adherent to the back of the uterus. And this is the same seen transversely now, This is the transverse measurement of the right ovary, a beautiful view of the islands of endometrium in the myometrium. This is very bad adenomyosis. So right ovarian endometrioma, and you can already see a left ovarian endometrioma, and both the ovaries, they're kissing and they're attached to the back of the uterus. There's the left one. And you can see these ovaries are called kissing ovaries. They're adherent to each other, they're adherent to the back of the uterus, and there's normally bowel adherent to this area as well. Looking at the sliding sign, we're in the longitudinal plane again. This is where bladder attaches to the uterus. It's that white line there. There's the internal os, there's the torus. You can see white fibrosis here, and you can see bowel glued to the back of the cervix, and you can see it's glued to the back of that endometrioma as well. So this is a frozen pelvis. In the transverse plane, looking at the area nearer the torus, I've got two nodules there of deep infiltrating endometriosis surrounded by white fibrosis. This was an atypical endometrioma. And here, again, I can see a bowel nodule. Now, there's the bladder, internal os, torus. So it's above this line. So this nodule is in the upper rectum. You can see some normal muscularis here, some normal above. And this is a bowel nodule with the overlying submucosa. It looks intact in that view. So it's upper rectum. And this nodule, if you keep looking up, is attached to the underside of this ovarian endometrioma. And you can see all that here. You can see normal muscularis there. This is the anterior wall of the lower rectum here. And then in the upper rectum, you can see this bowel nodule in the anterior wall. Looking at the submucosa. Now I'm looking at the bladder. You can see that the bladder is freely mobile on the front of the uterus. If there's a caesarean scar here, then the bladder might be a bit adherent. But I'm also looking for nodules of DIE in the muscularis layer there of the bladder, and in the space between the bladder and the top of the vagina or the front of the uterus. This is all areas where you might see endometriosis, but not here. And I looked at her kidneys and they were normal too. So looking at the whole pelvis now from left to right in the longitudinal plane, we've seen them all piecemeal. You can say that she's got a normal anterior compartment, including kidneys, adenomyosis, bilateral ovarian endometriomas, kissing ovaries, retrocervical nodules in the torus or uterosacral ligaments, an upper rectal bowel nodule of DIE, and a frozen pelvis. So the ABC of IDEA ultrasound, how I do it, I break it up. I have a systematic routine pelvic ultrasound, looking logically the same way at the different organs. Then I look for the sliding sign in the pouch of Douglas. Then I look for nodules of DIE through the posterior fornix. Then I do the soft markers, pelvic mobility and site-specific tenderness. But when you're learning how to do this, start by just checking for the sliding sign in all patients. And remember to be gentle. I've got lots of recommended videos and a book. You can screenshot this or come back to it later. And a lot of papers. These are the most significant papers, I believe, in the last 16 years on endometriosis. You can freeze the video, you can screenshot it. I would really urge you to read these papers. They're very good. And that's it. Thank you very much.